I saw when AVERTD came out, and I wrote an article about it, and there has been quite a bit of resistance to it. And I wanted to discuss a little bit of that with you. Now, I had mixed feelings at first, but when I spoke to I'm so bad with names, to your boss, he, from what he said, it seemed like a very reasonable test and information that doctors and patients should know. And so I wrote another article about how it was going to be used, but there still seems to be a lot of resistance. Now, you've got a doctorate of chemistry, you're certified in molecular biology, and you are the key account manager there at Solved.
Yeah, I am. I'm the genetics nerd. So my background, my PhD, as you noted, molecular, but I really specialize in genetics, inherited diseases. Developed a lot of assays, cut my teeth in diagnostics, developing non-invasive prenatal testing. So I was the scientist that developed the assay. It was complex NGS workflow, if you're familiar with NIPT. And so I was tasked to kind of commercialize it, but more to the role here is I was out there educating in a similar fashion you do for pain. I did that for genetics and prenatal and what non-invasive prenatal is, and the appropriate use, the inappropriate use, the strengths, the weaknesses, and being very forthcoming with that. So that was primarily my role for the last decade or so in that space. And so I've been here at Solved about 2 months, coming up on 2 months, and taking the mantle from Carrie with the edict to really go out and educate physicians, right? To your point, those that know, those that don't know, which is a surprisingly large amount, about OUD, what it means, its origins and genetics, and what can be done beyond current standard practice. It's kind of where I'm working to help educate. So that's why I was really excited to meet you and chat with you.
Excellent. Excellent. Now, I've looked at it pretty well, and you've identified a fairly large number of genes that, let me say this right, are associated with an increased genetic risk of addiction, right?
Correct.
Okay, and that's about 20% of the population carries those genes. Is that correct?
We have about a 20% hit rate in the all-comers population.
Okay. Now, the rate of addiction when someone has been exposed to opiates is lower than that. Do you attribute that to epigenetic and environmental differences?
Yeah, that's what and this is because my background is in genetics, and I would live through the GWAS era where we thought we find one mutation, we can correlate everything and solve the world. And then the big eureka of, hey, this is a lot more complicated than a single gene, anything. And it's a multifactorial thing. So it's not just one gene, it's multiple genes. And that's why a lot of our diseases have spectrums, right? Because it's nuanced. And then you've got behavioral aspects. And, everyone's got that uncle that you know. And so maybe you're going to be a little more cautious. There may be behavioral factors, a lot of intangibles. And I think that's why I like this test is because it is an additive, not a replacement. It helps to inform with a whole context. Like, clinical decision making is done, with context. And so this is just another arrow in the quiver.
How much of an increased risk of addiction, say, now, if someone has all of these genes, what is their increased risk factor that the physician should be educating their patients about before they decide to, with informed consent, use these medications?
Yep. So from the clinical study and the FDA study, it was an 18-fold increase of elevated versus non-elevated. So you took those two cohorts, and the group that was identified as elevated had an 18-fold increase of developing OUD when compared to the non-elevated set, which risk metrics in all sorts of disease states. I mean, BRCA is in the 4x, right? Smoking is to lung cancer in the 30s. This is pretty high from an initial outlook. So.
It's surprisingly high considering how complicated and multifactorial a condition like addiction is. But and a lot of these genes had to do with the nucleus accumbens did any of them directly have anything to do with the expression of the gene delta phos B, which has been associated with addiction?
I believe so. I'm not honestly as much of a genetics guy. I'd have to look at the RS numbers and pull that up right now. I do have it next to me, so I would have to specifically look that up. But I thought one of them did, and I can pull that up right now.
I believe so too, because I did look them up for my article. I had to look them up for my article. You know, even if it's like computer science. I have a computer science degree. I still have to get my nephew to help me with stuff because knowing how they work is not staying current with exactly what's going on right now. So it changes almost on a daily basis. And genetics and even epigenetics now has become a tremendously, I think, valuable tool for physicians. Now, and 18 times would be significant as a physician who's practiced clinical medicine and has treated addiction and chronic pain. I would like to know that so that I could tell my patient, you have an 18-fold increased risk, but here's what patients are afraid of. They're afraid that a doctor will run this test and tell them, hey, you've been on pain medicines for 10 years, but I'm going to have to stop them because you're at an increased risk. And now that I've ran that test, the DEA is going to come in and use that test and tell a jury that I ignored your risk.
Now, that is not the intended use of the test, and the intended use of this test is for acute opioid naive. So this is somebody that has not taken oral opioids, and it's new to this. So this, you know, for us, as I talk to clinicians, the use cases really end up, and this is not mine, it's where their discussions end up going, is they start thinking about that first or the wisdom teeth extraction on a kid that's when they're 18. You know, they go in for a surgery. They've talked about acute injuries, and they're going to need some surgical intervention to repair something that they know on the back end, opioids are going to be ordered. And that's the one where they're like, I'd kind of like to know if a pain management, you know, and this is where partnering with clinicians is really helpful. Is all right, you have this data. What are you going to do to it? Are you going to change clinical care? Are you going to change practice? How are you going to change that? And that's been kind of the first bit I've done here is talking to what are those alternatives, right? How are physicians using that information? It could be something as simple as, hey, normally I give 10 days, but I'll give 4 days of pain meds and then evaluate when the script needs to be renewed. Right, and they kind of work it within their clinical workflow, that sort of thing.
Right.
I've even talked to organizations that, independent of us, are trying to address opioid addiction by having alternatives to pain, and maybe more holistic. Like there's this organization called Goldfinch, I think, where they have meditation and all sorts of other things because pain is individual, and I'm preaching the choir here. Each person feels pain in a way that's unique to them, and each person manages it in a way that's unique to them. And so finding multiple modalities, whether it's reducing or adding safeguards into rescripting, or maybe it's just completely alternative ways, whatever works for somebody. So that's not our role, but I love to partner with people who have alternative ways of dealing with pain.
Well, I think that's the key to a successfully using any test like this. When someone has a heart attack or stroke, as a clinician, I'm going to probably put them on aspirin, and I can run a test and say, hey, you've got a slightly increased risk of bleeding disorders. You need to know that, because if I put you on this aspirin, I know that about 600 people a year are going to die from being put on that aspirin. I also know that about 10,000 are going to be saved from heart attack or stroke. So it's risk versus benefits. But right now in America, when it comes to opioid medications, everything is about risk and the benefits are being ignored or denied. And for an opioid naive patient, I would use it to educate them and say, you have an 18 times higher risk. I would suggest, why don't we try something else first? Because I agree that trying to avoid opiate medications is good practice. But Not using them at all is very bad practice because some people, most people, manage them very well, do not get addicted, and it is the only thing standing between them and dying in agony. And they will die faster if their pain goes untreated. So I see this as a tool. If they're in the 80% that doesn't have these genes, that doesn't mean that they can't get addicted. If
Right.
they are in the 20% that does have them, that doesn't mean they will get addicted. It's just to inform them you're at higher risk and to inform me that we should keep a close eye on everyone. But when you tell the patient, watch for these signs in yourself,
Yep.
that is your best tool. You only see your patient for 30 minutes, a month or so. And of course, they are with themselves all the time. So they would worry about this too. And if they're opioid naive, it's good to make them aware, I would think.
Yeah. And one thing I'm curious your thought on, because as I talk to institutions and physicians, and individual physicians, I get a very different conversation than when I do institutional, right? Because they have a different perspective. There are some institutions that they mitigate the risk of opioid addiction by going cold turkey on it, and to me, that is not that is I don't have a good tool, so I'm just not going to do it, and that's throwing your hands up in the air and giving up. And I think that's another cohort that I'm talking to kind of say that's not the best patient care either.
Here's the problem with that.
You know,
Scientists and medical educators, in our continuing medical education and the American Society of Addiction Medicine, American Academy of Pain Medicine, they all say, don't do this. You're putting your patient at increased risk of addiction.
Agreed.
But a doctor right now is being sentenced to 20 years in federal prison because a patient he had prescribed a few oxycodone to died from a cocaine and heroin overdose. And the argument was he had a drug screen that showed a drug, and you gave him another chance, and now he's dead. Now you are a drug dealer. So that's the environment that we're living in, and the doctors are extremely concerned that this will be used to prosecute them. And I have to say, I called one of the doctors who had done the continuing medical education and said, hey, this doctor's on trial. Would you please come to court and just tell the jury what you told that doctor at this meeting? Oh, no, we get federal funding. That would be a conflict of interest. So we're taught one thing and then prosecuted for carrying out what we are taught, not only what we're taught, but what's in the best interest of the patient. So chronic pain patients are afraid they'll be shut off. If this is limited to opioid naive patients, that should not be a factor. And there are doctors who are putting up some opposition because they are afraid that it will be used to imply that it's safe to use opioids in some and unsafe in others, when they would argue that actually mental health issues are the highest risk indicator for possible abuse. Chronic anxiety, depression, bipolar disorder, things like that. And
are you referring to those behavioral questionnaires that they generally should be asking before they write a script for opioids, kind of in that FDA black box, and you should do some?
Yes, and here's the problem with all that.
Yeah.
So I had a computerized system that would ask my patients these questions. They will often be much more honest to a computer than they will to a nurse or a doctor. But you're still going off what the patient tells you. You don't know if what they're telling you is accurate, either because they're being deceptive or because they simply have not faced the reality themselves, right? Because sometimes people deny the conditions they have. Very, very few people with serious mental health disorders see their disorders as severe as the rest of us may see it, or as it may affect their lives. So my argument to my fellow clinicians is this is better than what we have now, which is essentially nothing. We don't have anything objective. We have no objective way to measure pain. They're working on it, but still, it's enormously complicated. Cannot be done clinically. We have no objective way to measure risk of addiction, but this is an objective measure. And if it's used to educate the patient, I don't only think that it should be available, I think it almost should be required. if opiates are as bad now, with the understanding that the opiate panic and the opiate crisis and all of the deaths, that's fentanyl coming across the border. But the people who are taking fentanyl, they think they're taking oxycodone or hydrocodone or even Xanax or Ritalin. They found it in those. They're still voluntarily taking something that usually has an opiate in it, even if it's heroin. And so knowing which of your patients might have a genetic predisposition, I think lets you educate them better and inform them better. In the end, you can't control what someone else does, but at least they will be informed. And if it's used for information, I think that would be good. What will SOLVD do if this test is used at some point in the future to prosecute some doctor who, say, prescribes Tylenol 3 to someone after a wisdom tooth removal that got infected or whatever? So they've got an infection in the bone, horribly painful, dry socket, all that good stuff. And they prescribe Tylenol 3. 10 years later, that person develops opiate addiction, and they come back on that doctor. Will SOLVD stand by the education that it provides the physicians?
Yep. So obviously case-by-case basis for any of that, but that is why our educational material states that this is just a risk factor. It does not say you will, it says you may. And it's just enrichment. It's no different than the behavioral assessment, which, well, it's different in the fact that it's better and objective, but it still is just a risk factor. It is a multifactorial behavioral. It is complex. And that's why this is a hard nut to crack. And so I think from that standpoint, again, case by case basis, but we would stand by our educational material and the fact that we caveat it as an educational opportunity. It's a risk to have that conversation. Whether you're low, well, not elevated or elevated, risk is always still there. This just kind of says, is it riskier or less risky? But it does not take away the other factors that are out of everyone's control. So that would be kind of my thought on that.
So do you see this the same as the test that tells someone they have a predisposition to perhaps Alzheimer's disease, and by making these dietary and exercise changes, they can increase their probability of not developing that disease or of slowing the development of that disease? Whereas in this case, I think it could be a very strong tool for watch for these signs in yourself. Now, some would say that we should educate everyone about that, and we should. But if I tell you that you have an elevated risk, you're going to listen more than someone who does not.
Yep.
So, doctors may choose to tell the patients who have an elevated risk and just tell the patients specifically, but tell the patients without an elevated risk that, we don't find an elevated risk in you, but you are still susceptible due to all these factors, and educate that way. So as an educational tool and as an informed consent, especially with the direction that we're going toward with opiates, we have nothing to replace them. I know that they're trying a lot of alternative things, and there are alternative medications being improved. The latest one based on the endocannabinoid system, by the way, which I find amusing, that a plant with no medicinal properties somehow is producing all these medications.
Life's full of ironies, isn't it?
It is. Now, what about insurance companies? So one of the things that we have found as physicians is that when we run genetic tests, we get targeted. We get audited. We get our records reviewed. And it's one of the things that the Department of Justice has listed as an indicator of possible fraud is running genetic tests. How expensive is this test? Rough guess, where is it in there?
Yeah, so we are still, one of the primary things that we're doing is using budget impact models and looking at areas, because we're still testing the waters on that. So we're not entirely sure where we're going on that. So that is a TBD. We're working with systems and payers specifically on this, because you mentioned that, and like I said, I've been in genetics for genetic diagnostic testing for well over a decade, and dealing with that. And I have seen the labs that are not up and up, and I've seen the ones that are absolutely take the high road. And I don't disagree with the Department of Justice. And that's why we work with institutions on what makes sense. Because this is a lifetime test. Like you noted, it's a genetic predisposition. Your germline is what it is. It's not like screening tests or genetic tests in which I'm thinking of like Grail and those oncology liquid biopsies where they're charging $1,000, but you're doing it annually for from 50 on. I mean, that's where you start to get like, this is some serious money. You better be a good test.
Right, right. And I recommend that physicians do not make profits from the tests they order. I know that's really hard because as doctors, reimbursement for seeing patients has dropped for the last 17 years, every year for the last 17 years. It gets to be hard to keep your doors open if you don't make a profit somewhere. But I think that making a profit from labs opens the doctor up to charges of over ordering labs, especially if you're a proactive doctor and you do want to educate your patients and you want to make sure you're up to date with the latest technologies. Now, one of the factors that will determine how much it costs is how often it's used. And that's impossible to determine until you know what the reception is going to be. Where is the highest pushback that you've seen? Who seems most opposed to the test to you? Most of the pushback I see is from physician groups that are sort of anti-opioid and have created their own kind of spreadsheet sort of rating system.
I don't, I don't agree with that because I think this is complex. So, and I know I'm preaching to the choir. We're talking about pain management with opioids, opioid addiction. I think the addiction pathway, addiction itself, is complex because it's hardwired. There are certain factors of addiction that need to happen. And when I'm thinking hunter-gatherer, you get food, that's delicious. You need it for survival, do it again, right? You have to have that hardwired because if it's a decision, you're not going to survive. That's back in the day, right? So anytime you have that kind of hardwired behavioral connection and a stimulus that causes it, you're going to have a likelihood of addiction, whether it's an actual drug or an external stimulation. So in a broad brush, addiction is complex and multifactorial. So genetics is just a combination. And when we were doing our initial studies, we were looking for comorbidities with other addictions, right? Nicotine, alcohol, gambling, anything can be a comorbidity when we're talking about this brain reward pathway. This just happens to be trained on opioids. So that was a long preamble to say what causes one to have that kind of hit the button, get the pellet sort of thing is genetics can give a predisposition, but behavioral environmental may push it over the edge, may push it to one way or the other, right? Say, and I'm making this up as a hypothetical, but you could have all the genetics for opioid use disorder, but you're in an alcoholic family where alcohol's the thing. Maybe it doesn't fully hit that thing, but you just find alcohol works, right? And you never experience opioid use disorder, but you get the comorbidity because it ticks, 9 out of the 15 boxes. Again, as an example. So where I think those organizations come into play is maybe there are nuances that are environmental that can be captured that together you get more specificity on the things you should be looking out for or the directions it may go.
So this would be an added tool, more of an educational tool to properly inform the patient and the physician about the patient's risk factors, and then the other measures can still be utilized.
Yeah, 100%. So when I was in non-invasive prenatal testing, right, in brief, you're looking at circulating cell-free fetal DNA, but you get 90% of mom. Early days, we started seeing something that looked really anomalous, like genetic instability off the charts. And that's when we discovered that that's a potential circulating tumor DNA, and that we were really seeing malignant DNA that was being circulated in the maternal bloodstream that indicated there was cancer. Why I bring that up here is what we would do is call the physician and say, hey, this looks like cancer. We don't know where it is. We don't know how to work it up, but cancer, right? We just dropped a bomb in their lab with no direction. Right? That's a problem, right? We just said hot potato to the physician. So when you have information, now this is much more directed than that, but if you can't drop in information without call to action for the physician. And so that's where any additional data set that we can add into it will help refine this. That makes
yeah, that's very interesting. I would, if you could collect enough of the tumor cells, you could RNA them back to see which genes were active and give a tissue idea.
You actually can do that. So we were able to identify where the DNA came from by isolating the fragmentation, because the fragmentation is a hallmark of the expression, and each tissue has a different expression. So you actually can trace it back. This came from the kidney based off of some patterns. We never got fully into that. I mean, this was just on the nerd genetic side, theoretical, but yes, to go off on
that's science. That's science. That's talking about the potential in the future for tests that you go into your doctor's office and he says, hey, we need to keep it. I don't see any sign of kidney cancer right now, but we've got a few cells that are going that direction, circulating in the blood, so we need to keep a close eye. We'll do an ultrasound every 3 months, 6 months, whatever. That is the future of medicine, and I think this is also the future of medicine. I think we like to disregard the physical side of our brain as it produces our mind. I try to, when I'm teaching about the brain, I try to say it's an orchestra. You've got all these instruments. You can take out any individual instrument. The tune can still be played. It's not just quite the same, right? So the brain can take certain insults and you can still play as a symphony. At the same time, which symphony is played on which instrument is determined more by epigenetics and environment, but you are still limited by the physical structure of the mind. And if someone has this predisposition through no fault of their own, and you start them on a course of treatment without knowing the risk, then in my opinion, it's always better to know the risk. And of course, people worry about being discriminated against. Told, okay, you've got cancer, but now we can't treat you for pain because you had an elevated genetic risk. And I think that's something that will have to be fought. But I don't think that we should throw out an objective test that has an 18 times risk factor sort of risk potential predictability because we're afraid that it might be misused. I think the cure is to go after the misuse, and in your educational materials, it will be very, very important that you clearly lay all this out. If someone is not willing to go into court and say something, nothing comes with you. No textbook, no CME, nothing. And finding an expert who's expert at all of this is tough to do. So it will be important to clearly lay it out. But
I had something I wanted to throw at you, and this was something I was discovering when people were talking about what are people going to think about the stigma, the information that they get provided. And I asked the physician, I said, in your standard of care, when you do a behavioral assessment and then modify your pain management based off that assessment, do you say, hey, I think you might be potential to be addicted to opioids because I did this behavioral assessment, so I'm going to change your pain management? That doesn't get said. No one says that right now. They kind of document on the back end, they modify, but they don't have that conversation right now. So I would almost argue that current clinical practice is more nebulous and obscure and less empowering for the patient than this would be, because this involves.
It absolutely is. And physicians are afraid to broach these subjects with the patient. One of the risk factors is childhood traumas, and women with childhood traumas are being denied treatment and taken off their treatment routinely. And that is a fault of medical education. The doctors are making the mistake, because if the patient is stable on their medications, they should not be taken off. That you can observe them more closely or whatever. They always say you should do everything perfectly every time. That's, of course, humanly impossible. My main belief that I think this test should be done on any opioid naive person is so that they know. They might go in and say, I have an 18 times higher risk factor, And the doctor might say, I'm going to give you some Tylenol 3. And he's saying, no, can you give me something non-narcotic? Can you give me, a super strong naproxen or Voltaren or something that does not have that risk factor? Because there are other things we can use. And I would argue that we do genetic testing right now. We just do it through what's called anamnesis, by talking to the patient. We say, do you have a family history of alcoholism? And if they say, well, yeah, my dad, my uncle, my grandpa, you're like, all right, well, that doctor should know. We might not want to use gabapentinoids in you because that binds the GABA receptor the same as alcohol. Do you see this as any different than that sort of evaluation?
No, you are spot on exactly. So I've always thought, and even in a lot of, again, I keep using NIPT, is when we look at birth, complications in birth with regards to genetics, and you often look at family history, and that was a really good indicator, often better than maternal age, to indicate that. And family history, in my mind, is always a surrogate for inherited genetic predisposition. That's just code for it. And we called it family history because we didn't have the tool set. Now we have a tool set, right? BRCA is a great example of that because you have a family history of breast cancer and cervical cancer. Well, that was the surrogate until BRCA came along, and now you can be like, duh, that's why, right? And so it flips the script. The reason why we still use family history is we haven't, boiled the ocean for all the things, and it's still complex. So that is just like this. We've got this genetic, but that's not the end all be all. So we still need to have these behavioral history sort of things. And together we will iterate into a better and better direction and information.
Now, the other thing genetic testing lets you do is it lets you approach a woman who says, hey, my aunt, my mother, they all died of breast cancer. My grandmother died of breast cancer. I think I'm a high risk. I'm going to go ahead and have a double mastectomy. Is there any test you can run to see? And you can run the test and say, okay, you do not seem to have inherited the same genes they have. Your risk factor genetically looks to be about the same as average. Maybe the mother was ran and she was, BRCA positive, and you're saying, okay, she had something that she did not pass on to you. That's extremely important for patients to know. And so it goes down to education and an informed patient. And I think informed patients have the right to be part of the decision-making process. And that's a debate right now in the United States because patients are being taken out of the decision-making process. Their considerations are being disregarded and not even listened to. And I think that's a tragedy. Will there be patient education? Go ahead, please.
I was going to go exactly where you were asking. Is that's one of the things I like about this test is informed consent from the patient is required for this test, which means you have to have a conversation with them, which means they are now empowered. There's no shadow sort of banning or black mark on your file in your medical record that you're unaware of. It's eyes wide open. So we just brought some marketing folks on board, and the first thing I'm talking about is we need to have patient information. We need to educate the patient. They're a decision maker within this process. And you brought up the perfect scenario. Doc is like, here you go. Here's some Oxy. Here's some Tylenol 3, and they can say no, right? I'm good. Because what's funny is we were actually doing more and more into deep dive of kind of the scripting pathway and the amount of scripts they get. And then people will actually not fill them because they suspect they don't want to have that in the house. So the doctor already gives them a script and they're making that decision. I'm not going to fill that script. Or it's automatically filled. It's at the CVS, but they never pick it up. Or if it does get picked up when they're DC'd, they don't even touch it and open it. Now that's risky because now you got opioids sitting around that you never wanted, didn't need. So anyway, I'm just kind of echoing everything you're saying.
There's a paradigm shift where doctors have gone from being pilloried. If anyone complained of pain, you'd be. I have a good friend who's a pain specialist. The only time he's ever been in front of the medical board was when he stopped someone's pain medication, which can be a dangerous thing to do. But in this case, it was for behaviors that were not conducive to continuing treatment. So what would be the optimal patient and what would be the optimal situation? So I'm a fresh new doctor. Who should I run this test on? What should I consider, and how should I run it as an education for whoever's watching this?
Yeah, so if I take, obviously there's the intended use, which talks about, you know, opioid naive patient 18 and older that is about to be prescribed by their physician 4 to 30-day oral opioids for, you know, a post-surgical, post-intervention, whatever it is that's going to cause pain. So that's the intended use, right? Broad brush, you know. But where I think that goes into is that the proper use would be the physician who does the procedure. Is that procedure going to cause a lot of pain, right? Is this a painful thing? Is this a spinal fusion? Is this something that, you know, any patient getting this is going to be in a lot of pain? I think that's one to really, because that's where they have the potential, the long-term exposure, 10 plus days of opioids. And that's probably where you'd want to know, because what's likely going to happen, and again, the physician clinician would know this, is, hey, I'll give the 5-day, whatever my opioid stewardship kind of institution says, they're 90% of the time going to come back. And when they come back, I want to be able to know, am I going to be like, sure, here you go. Again, they have the behavioral, they have this, or is that going to be one like, okay, maybe a couple more, let's have a talk, maybe let's bring you in. So I think that might be a good initial use case of somebody, because that kind of enriches the population risk. Again, it's all about risk mitigation. And so to me, that might be a good option for a physician just getting into this.
Now, one of the things patient will worry about is patient privacy, privacy of genetic and medical records. Genetic tests have a special privacy law that applies to them that does not apply to other laws, to other tests. Is there any potential in the future or whatever for patients to be able to order this test on their own, for them to be able to order the test so that they will personally know?
I mean, no, here's why. And I always think about this is education, this is information that I think needs to come with somebody there to hold your hand, right? Or someone there to say, what does this mean for me? And that's why I educate both physicians and patients, because physicians need to have that conversation or know what to say to have that conversation. And I think patients can't do this alone, right? If there were a scenario, and I don't foresee one, it would have to come with back end, whether it's genetic counseling, other physician or clinician conversations. It cannot come back in isolation, because you can imagine scenarios by which that may devastate a person. If they, my father died of addiction, my uncle died of addiction, my grandfather, you know, and then they're like, great, now it's me. I don't want to do this. So that's why we always engage with mental health professionals when we talk about opioid use disorder and in any of our studies and conversations.
Excellent. Where can doctors find out more about this? Is there a website or anything set up where they can go to educate themselves about this?
Yeah, so we certainly have our Solved Health website that has information for providers, kind of how to access the test, kind of high level what the test is. We have our HCP FAQs, a lot of acronyms, but that's something that was produced with our FDA approval that is mandated to go. In fact, I've always got them sitting around me because I always have them and refer to them. But there's that material that's available as well. And it talks about these things that we're talking about now. And this is part of the FDA package, right? Any physician ordering this must go through a mandatory training, so you understand, and then must receive these FAQs and provider-related documents, as well as patient-related documents. And these provider-related documents, just so you know, you only need to have it once, but we put it in every kit, because I want it to be first and foremost. Like, I don't want you to forget about this in 6 months. So it's going to be in every kit. So you're like, oh yeah, FAQs. Oh yeah, FAQs. Oh yeah, you know, first and foremost. Yeah.
And that's SOLVDhealth.com.
Yeah, yeah. No E. Yeah.
Is there anything else that you would like to tell any clinicians or patients that might be watching this video?
Yeah, this is a partnership. This is something where we're working with clinicians to help improve opioid addiction crisis. This is something that can be done in isolation. This is something where we need to come together and work in unison with all the tools available. So I'm looking forward to talking and reaching out to any clinicians about how this information can be used in the best way for the patient.
I can say I am very happy to see an honest effort to use science instead of opinion and stigma, because quite often patients are blamed for their medical conditions when it comes to chronic pain, addiction, alcoholism, things like that. When sure, we can always fault whatever behavior we have, but the difference is that whereas some people can try something for the fun of it and never have a problem with it, other people can try it once and never be able to put it down. And knowing which category you might be in, just getting a clue about it, could, I think, be enormously helpful to the patients. And I want to thank you for the work you're doing.
Well, thank you for the opportunity to have this discussion. I learn every time I talk to a clinician like yourself. I learn something new and continue to spread the word. So I appreciate it.
Thank you very much, Doctor.